Hi, I'm Dr. Chin Nokoro, Children and Young Persons Asthma Lead for Barts Health and North East London ICB. And during this year's Ask About Asthma, I'm just excited to talk to you about asthma diagnosis in childhood. Asthma is common and getting more so. Moreover, it is an imminently treatable condition that kills more children in the UK than in any economically comparable European nation. Despite this, there is evidence that asthma is underdiagnosed. There are more children on GP registers prescribed inhaled steroids and beta agonists than are coded as asthmatic. Also worrying are the overdiagnosed, the group of children inappropriately labelled and treated as asthmatic who are not, or who may have some other treatable diagnosis. Accurate diagnosis is important to guide appropriate treatment with conventional medications, but also to phenotype asthma so the difficult to treat cases can access newer, groundbreaking therapies. The right treatment is more likely to work and therefore more likely to be taken by the patient. Also, an accurate picture of the burden of asthma care allows us to plan and provide the requisite resources to tackle the problem. Asthma is a disease of cough, more often dry than wet, and not barking like in croup or floppy airways. Also prominent is wheeze, a whistling, expiratory noise usually heard with a stethoscope, as compared to stridor, which may be audible across the room and usually on the breath in. Breathlessness and chest tightness are common, but less discriminating features, and all of these symptoms are often triggered by exercise, infection, in bed at night, or by allergies. Asthma usually responds to treatment, but beta agonists, the blue inhaler, usually take 10 to 15 minutes to work, and metered dose inhalers, as pictured here, work better with a spacer. Failure to respond, or sometimes near instantaneous treatment response, should raise suspicion, while not using a spacer requires urgent intervention to ensure appropriate medication delivery and reduce side effects. Needing rescue inhaler more than 3 times a week is a sign of poor control, as is using more than 3 to 6 salbutamol MDI inhalers per year. GP and pharmacy records can highlight high-risk children and also those who are not regularly given their controller inhaler. So ask, has a trial of inhaler been given and what was the response? Does the child struggle to gain weight, frequently produce sputum, have fatty stools or choke or vomit during or after feeding? Do they have symptoms with certain food or physical exposures, or have persistent nasal discharge, or perhaps a history of neonatal pneumonia? All of these features may suggest an alternative diagnosis. As asthma is a disease of varying symptoms, examination can often be normal. It can be helpful to ask patients to record symptoms, including video, on their smartphone. This can help distinguish between wheeze and other sounds like stridor or rattles. During an attack, a patient will have wheeze, unless severely unwell, where breath sounds may be absent. This is an emergency. Patients may not appear breathless during an attack, particularly if they are used to having symptoms. A fast heart rate can help with assessment, although this may also reflect rescue medication use. Long-standing uncontrolled asthma can change the shape of the chest, with hyperinflation, or, as pictured here, the development of a Harrison sulcus, where the diaphragm pulls on the lower rib cage. It's helpful to look for other features of allergic disease, like eczema and rhinitis. These increase the likelihood of asthma, and treating rhinitis can actually improve symptoms. In terms of risk factors, while a tobacco odor should prompt smoking cessation advice. Finally, your examination may reveal features of non-asthmatic disease, such as growth faltering, persistent wet cough or crackles, clubbing, facial swelling, or urticaria, or even dextrocardia. The presence of these should prompt a rethink. Peak expiratory flow rate measurement is the most basic physiological test for asthma. It is limited in information value but is accessible, cheap, and reproducible. Patients blow through a sterile or disposable mouthpiece as hard as they can, recording the best of 3 similar values. Patients can keep a diary of readings to aid in diagnosis, and this enables clinicians to calculate peak expiratory flow rate variability, a measure of asthma control. Peak expiratory flow rate, or peak flow, also helps children who over or under perceive their symptoms to get a sense of whether they need rescue medication or medical help. Arguably, the gold standard physiological test for childhood asthma is spirometry. A patient-skilled operator can achieve reliable results in the majority of school-aged children of normal development and a significant minority of 4-year-olds. Children take a deep breath and produce a maximum forced exhalation and maintain exhalation until measured flow ceases. Clinicians examine flow volume curves as well as comparing flow rates exhaled at different stages of the maneuver with age-standardized reference ranges and also with previous values recorded by the patient. Key metrics are the FEV1, the forced expiratory volume in 1 second, the FVC, the forced vital capacity, and the ratio between these. The response of these baseline measures to bronchodilator, a greater than 12% increase is deemed significant, bronchoprovocation, such as with inhaled mannitol, and to protocoled exercise regimes, provides greater evidence of airway reactivity or poor asthma control. Exhaled nitric oxide measurement is a marker of allergic or eosinophilic airway inflammation and is often used to assess steroid responsiveness and as part of decisions on inhaled steroid dosing. A patient whose exhaled nitric oxide doesn't reduce with appropriate dose inhaled steroid may need a higher dose, a different device, improved compliance with treatment, perhaps treatment of their allergic rhinitis, or indeed may be steroid resistant. These patients need specialist referral for trials of alternative treatment. Other pointers towards allergic type or steroid responsive asthma are measures of allergy-associated antibodies, so-called IgE, and cells such as eosinophils in the blood. There is a national drive to establish diagnostic hubs offering these tests in primary care. Doubts about their appropriateness stem in some quarters from difficulties in interpretation and concerns about testing quality and clinical responsibility. This chart shows the British Thoracic Society's SIGN approach, whereby a focus history divides children into high, intermediate, and low probability of asthma. Those with high probability of asthma based on history, examination, treatment response, and peak flow variability should be coded as suspected, should have a symptom assessment via the asthma control test or other measure, and ideally a measure of peak flow variability or salbutamol response, followed by a trial of preventer treatment, whereby a positive treatment response, which would be indicated by reduced symptom score, or improved peak flow or spirometry, can confirm the diagnosis. Those with a low probability should be investigated accordingly, looking for other disease as indicated by their symptoms and signs, while those with intermediate likelihood may benefit from physiological and immunologic testing with lung function and allergy investigations to support or refute the diagnosis. This second chart shows the NICE approach, whereby all over 5s undergo spirometry, proceeding to exhaled nitric oxide depending on the results. This last chart illustrates a difficulty in interpreting the various tests, with Venn diagrams indicating the degree of overlap between children with high exhaled nitric oxide, bronchodilator reversibility on spirometry, or low forced expiratory volume in 1-second ratio. This underpins perhaps some of the resistance to the widespread rollout of diagnostic hubs in some quarters. That's about the end of this talk. I hope I've made some sense. In summary, asthma diagnosis involves the integration of multiple factors of history, examination, testing, and treatment response. They won't all always agree, but they all play a part. If something doesn't fit in any of these domains, please don't hesitate to ask for help via your local pathways, usually via referral to a tertiary centre. If in doubt, escalate. Thanks very much.